This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we are diving into a topic that sits at the intersection of pediatric neurology and peripheral nerve surgery.
And I'm Dr. Alara. Today we're looking at a fascinating new study from Hand, New York, titled Nerve Transfers for Treatment of Upper Extremity Paralysis in Acute Flaccid Myelitis. This paper, coming out of the Medical College of Wisconsin, addresses a really challenging patient population, school-age children with devastating motor deficits following a viral prodrome.
It's a timely discussion, Alara. Acute Flaccid Myelitis, or AFM, has been on our radar significantly since that peak incidence in 2014 and 2018. While the numbers dipped during the COVID-19 pandemic, likely due to social distancing, it remains a rare but potentially debilitating disease. For our residents listening, what exactly are we looking at when a patient presents with AFM?
Usually, it starts with prodromal upper respiratory symptoms and a fever, but the hallmark is the rapid and asymmetrical progression of flaccid paralysis. It generally affects mimetic, respiratory, and proximal limb muscles. The paper notes that diagnosis is often supported by MRI findings, specifically longitudinal T2 hyperintense lesions of the spinal cord gray matter and CSF analysis showing lymphocytic pleocytosis.
And the prognosis for these kids is often quite grim without intervention. The paper mentions that 90% of patients do not experience complete spontaneous recovery.
Exactly. And that's the frustration. Medical therapy, IVIG, corticosteroids, plasma exchange is often equivocal in terms of efficacy. Physical therapy is the backbone of treatment, but many patients are left with residual deficits that severely limit their activities of daily living, or ADLs. That's where the surgical intervention comes in.
The authors present two cases where they utilized nerve transfers after conservative treatment plateaued. This is a critical point for neurosurgeons: timing. In this study, the patients failed roughly 6.5 months of conservative treatment before being referred for surgery. Why is that 1 year mark so important in your reading of the paper, Alara?
It's all about the neuromuscular junction. The paper emphasizes that we need to regain function before the deterioration of the neuromuscular junction of the denervated muscle. If we wait too long, the motor end plates disappear, and no amount of nerve reinnervation will restore movement. The study suggests that nerve transfers within 1 year of symptom onset appear to be most beneficial.
Let's look at the objective metrics they used. For a neurosurgical resident or fellow, how are we measuring success in these peripheral nerve cases?
They use two main scales, the Active Movement Scale, or AMS, which ranges from 0 to 7, and the Mallet classification for shoulder function. AMS 0 is no active contraction, and 7 is full range of motion against gravity or variable resistance.
Let's dive deep into patient 1. This was a 9-year-old male, left-hand dominant. He had classic AFM findings on MRI, a T2 hyperintense signal in the left ventral spinal cord from C3 to C6. Alara, walk us through his preoperative deficits.
It was quite severe. His AMS for shoulder abduction and elbow extension was 0.7. Elbow flexion was only 2.7, which means motion was less than or equal to 50%. On the Mallet classification, his shoulder function was essentially a 1 out of 5 across the board. Abduction, external rotation, hand-to-head, hand-to-mouth, all nearly impossible. He couldn't tie his shoes, zip a jacket, or even use scissors.
So the surgical team decided on a very comprehensive reconstruction plan. They didn't just do one transfer. They performed 4 distinct transfers in the upper extremity. Let's list those for the listeners, as this is the meat of the neurosurgical technique.
First, they transferred the spinal accessory nerve to the subscapular nerve. This is a classic move to restore shoulder stability and rotation. Second, they took the medial pectoral nerve and moved it to the axillary nerve to help with deltoid function.
And for the elbow?
They performed a fascicle transfer. They took a motor fascicle from the flexor carpi radialis, the FCR, and transferred it to the motor fascicles of the biceps and brachialis on the musculocutaneous nerve. Finally, to address intrinsic hand function, they did an anterior interosseous nerve, or AIN, transfer to the deep motor branch of the ulnar nerve.
That is a high-stakes reconstruction. Now, the results for patient 1 were quite remarkable, but they didn't happen overnight. This is something we always have to counsel families on. Nerve regeneration takes time.
Right. If we look at the AMS data from the paper, at 11 months post-op, his shoulder abduction went from 0.7 to 5.7. By 32 months, he was at a 6.7. His elbow flexion, which started at a 2.7, reached a full 7.7 by 23 months.
What's interesting is the elbow extension. It started at 0.7 and only reached 4.7 at the 32-month mark. 4.7 means full motion without gravity. It's an improvement, but it highlights that some functions are harder to recover than others in the setting of AFM.
Definitely. But look at his wrist extension. He started at 0.7 and reached 6.7. His finger flexion stayed strong at 7.7. Functionally, the paper states he had near complete recovery of function and significant improvement in his ability to complete ADLs.
Now, let's briefly touch on patient 2, the 2-year-old female. Her presentation was slightly different. She had an ill-defined flare hyperintensity in the left cerebellum and spinal involvement. Her surgery was also focused on the shoulder.
Correct. She underwent a transfer of the left spinal accessory nerve to the subscapular nerve, similar to patient 1, and the motor nerve of the long head of the triceps was transferred to the axillary nerve. Even in a patient that young, the study notes significant improvement.
One thing I want to highlight for our practicing surgeons is the asymmetric flaccid paralysis mentioned in the paper. Because AFM often spares certain muscle groups or affects them asymmetrically, it creates these perfect donor opportunities where we have a functioning nerve like the spinal accessory or a fascicle of the FCR that can be plugged into a non-functioning recipient.
That's a great point, Dr. Aris. The paper emphasizes that AFM results in pure motor deficits. Sensory neuron conduction remains intact. This is why nerve transfers are so viable. We aren't dealing with a loss of sensation, just the loss of the motor highway to the muscle.
The discussion section of the paper mentions that although the incidence of AFM has decreased recently, likely due to hygiene practices during the pandemic, the frequency of reported cases has decreased, but the severity for those who get it remains high.
And the medical management, IVIG, corticosteroids, the authors are very clear that the efficacy is equivocal. This really puts the onus on the surgical community to offer these nerve transfers when physical therapy plateaus.
So, to summarize for our listeners, AFM is a gray matter disease of the spinal cord in children. When you see that persistent weakness after 6 months of therapy, don't wait past the 1-year mark. Nerve transfers like the spinal accessory to subscapular or FCR fascicle to musculocutaneous can provide near-complete functional recovery.
It's a message of hope for these families. Seeing a child go from a 0.7 on the active movement scale to being able to tie their shoes and go to school is why we do this work.
Absolutely. Elara, thank you for breaking down the data from this study.
My pleasure. It's a great reminder of the power of peripheral nerve surgery in pediatric populations.
That's all for today's episode of the Neurosurgery Hub podcast. We hope this deep dive into nerve transfers for acute flaccid myelitis helps you in your clinical practice and your board prep.
We'll see you next time. Stay curious and keep learning.
Goodbye.